Hello, everyone. I'm Megha Prasad, joined here by Dr. Akiko Mehara to discuss the very interesting study that she just published on CTOs and myocardial bridging. Dr. Mehara, can you tell me a little bit about your recent study and how you thought of the idea?
Sure. I think because I have a lot of experience to see the CTO IVAS, and then when we do the LAD-CTO, I recognize myocardial bridge is more than regular non-CTO LAD. That's just my experience. And then I saw that's important. And because whenever you have the myocardial bridge, you look more disease angiographically. And then if that's on the CTO, you may overestimate of the CTO length. And then that may translate the procedure injury, and then finally longer stent, and then finally they may be associated with a long-term outcome. That's really based on the everyday case. That's number one. And then my fellow, he looked for a bunch of the IVAS and the CTO LAD and non-CTO LAD and confirming that's actually true.
That's very fascinating. So tell me, what do you think it is about a myocardial bridge that results in the vessel eventually becoming occluded? Why do you think there's an association?
I'm not sure the association why the bridge may most likely causing the CTO. I don't think that's the way. Meaning, like when we consider what is the pathophysiology of the CTO, is maybe somebody having plaque rupture or erosive thrombotic event, and then somehow occluded. But some people may feel less, and then at the same time, it's already collateral developed, and then finally the CTO could be appear. So that's, I think, like we don't know, but that's a whole, that we believe as the pathophysiology of the CTO, right? And in such, if the patient having the myocardial bridge from the beginning, of course, that's starting from the bone, and then they are more likely ischemic because some of the bridge causing the ischemia, and then they may have more resistance of the ischemia. And then once something happen proximal to the CTO, proximal to the bridge, and they occlude the artery, most likely causing the CTO appearance instead of like the MI. I don't know, but that's just like, we didn't prove these things, but this is kind of the hypothesis background.
That's fascinating. What do you think is the role of intravascular imaging in CTOs in general, but especially given your recent findings?
Sure. I think what is important is everything from the beginning to the end, where the proximal cap, and once you cross or you overlap and retrograde wire and antegrade wire, you are in the correct location, or you can meet together, or what's the button size of the reverse cut, and at the end, what's the normal to normal and how big the artery. So whole process is really important to go through the IVAS. That's we know, but especially for the muscle bridge, or especially in the LAD, as I said, when we compare the CTO with muscle bridge versus CTO without muscle bridge in the LAD, with muscle bridge, many times we feel the CTO is longer than the real. So the discrepancy compared to the angiographic appearance and true CTO length is typically looks longer in the CTO with myocardial bridge. And then people starting ballooning from the very distal to the proximal. And then at the end, when we do the IVAS, we recognize already inside of the bridge was completely injured. Meaning, typically inside of the myocardial bridge is no disease. That's many, many times we recognize. You don't need to stent, or you should not stent. But because you confuse, my CTO length is much longer than real, and then you balloon everywhere. And then when we review the IVAS already, everywhere is dissected. And then that's for limiting dissection. And then maybe we have to put the stent into the bridge, which is unfortunate. So doing the IVAS, knowing where exactly the CTO segment and where the myocardial bridge, and then avoiding the stent into the bridge is very important. And importantly, whenever we look into the CTO with myocardial bridge, CTO is never extended into the myocardial bridge, always proximal to the bridge. Then we just have to understand where is the bridge, where is the CTO segment.
So a key take-home point for me is from the study that, I should be imaging before I balloon after crossing a CTO. Would you agree?
Yeah. Or just at the site of the CTO, meaning you are very confident this is a closed space. And just go through the IVAS, open that segment, not too much, and then do the IVAS to understand what's going on, especially in the LAD.
That's fascinating. One last question for you. In terms of OCT versus IVAS, how difficult or easy is it to appreciate myocardial bridging on OCT, especially as we see new technologies coming up?
I think you can easily detect. Actually, to me, it's not big difference. So as long as you understand how it looks like this, I think not a big deal. And by OCT, because we are looking at the muscle, so the appearance looks quite similar, like the media, meaning low intensity and abutting to the vessel area. So that's we can recognize by bridge. So I think no problem by OCT. Of course, this is a CTO, and many times do the OCT is difficult. So that's it.
Yeah. Any final thoughts regarding this paper or future directions that you'll be taking as a result of your interesting findings from this analysis?
I think because we see this is really retrospective data, and then people know the bridge, but people doesn't know how often in the bridge in the LAD. So even the Columbia data, many of them was already dissected. So I think number one, we have to understand 40% of the LAD CTO having the bridge. So that's a basic knowledge. And then knowing prospectively, whenever you do the CTO in the LAD, you do as much as early IVAS to understand where it is, and then don't put the stent long in the LAD CTO covering the myocardial bridge, make it better outcome. So prospectively, we would confirm that's really work, and then finally we have the better outcome on the LAD CTO.
That's fascinating. Really appreciate your time today, Dr. Mehara. I learned a lot, and I think our viewers will as well. Thank you so much for taking the time, and we'll see you again soon.
Thank you.